Hello everyone, welcome to today's ICU training course. We are coming to the fourth episode of the whole series in the pharmacotherapy. I'm Dr. Yahan Li from Wanfang Hospital. Today we're going to talk about a focused anti-epilepsy medication that is so-called phenytoin. So we're going to mention a lot about the clinical pharmacokinetic issues, whether that is critical ill specific or generally, and pinpoint is to have a more thorough understanding of the pharmacotherapy and pharmacokinetic and some calculations. We are going to focus several learning objectives. The first sections to recall the following information: the facts of phenytoin in pharmacokinetics, including the volume, the Vmax, the Km, and the percentage of the normal protein binding ratio. Therapeutic range of phenytoin as both in the total drug concentration and unbound, so-called free-form drug concentration. Phenytoin serum level range, at which that highly occurs in certain major side effects to remember. The BA, the bioavailability of oral form of phenytoin. The types of pharmacokinetic drug interactions involves phenytoin or induced by phenytoin. And then the last but not least, definitions of Vmax and Km, those two important pharmacokinetic parameters here, and how each of both constants relates to the intrinsic clearance, so-called COI. And then the equation that adjusts body weight when we are trying to dose phenytoin for the obese patient. Last, equation that adjusts a phenytoin serum level based on a serum albumin and renal function. And the second paragraph try to explain the following relationships after today's course, including why the serum concentration of Michaelis Menten drugs, such as phenytoin, that would increase disproportionately to a dosing change in comparison to drugs eliminated by first-order process. Second, the difference between first-order, zero-order, or mixed-order elimination in terms of a plot of whether clearance to daily dose and a plot of the steady-state concentration versus the daily dose. Third, why there is a causation concern about potential toxicity when the phenytoin which steady-state concentration is greater than the Km. Then how the changes in protein binding of phenytoin that could affect its clearance, volume, and therapeutic effect. And last, how an increase in the free fraction of unbound phenytoin that will be expected to affect its total and its unbound steady-state concentration. Lastly, we have to the pinpoint to learn about the pharmacokinetic is to apply these knowledge fact clinically. So for the conclusions, making decisions after you're analyzing and evaluating. These are the following facts that you should be able to know or try to calculate the details if these assets are available to you in the future. First, derive the patient's own Vmax and Km according to their daily dose of phenytoin versus the clearance. And then calculate the following fact, whether from Km, Vmax, estimated Km with a certain given population average Km, if only one concentration is available to you. Calculate the daily phenytoin dose to achieve a desired concentration under a given these Vmax and Km. And then calculate the steady-state concentration or to estimate it as a result from a specified daily phenytoin dose, Vmax and Km. And the third categorized is to calculate the exactly dosing regimen, including the loading IV dose and the maintenance dose for both obese and non-obesity populations. And last, determine appropriate time of therapeutic level monitoring for loading and maintenance dose. When is the appropriate time to sampling order a drug level? Alright, so let's start today's course. First, let me preview what is a Michaelis-Menten model as a some review to you. So many of you may, according to the knowledge regarding the therapeutic drug monitoring, most of the medications follows as the first order class. That is, if we look at the left-hand chart here, the plot with those daily doses versus the steady-state concentrations, you can see normally any medication goes to the first order degree. That is, the higher of the daily dose, the higher the concentration proportionally grows. But as for the Michaelis-Menten medication, or so-called capacity-limited saturable metabolisms, or the most known as the nonlinear pharmacokinetic, that is, the dose concentration relationship goes disproportionately. That is, when the daily dose follows under certain regimen of the day, then the dose concentration relationship is linear, presents as the chart here. However, when the dose goes larger and then the concentration goes up disproportionately, and that is the daily dose versus the steady state concentration. How about the daily dose and the clearance in relationship? Here is the plot of that. You can see when the daily dose still under certain daily range, that clearance remain constant, just as first order medications. But when the daily dose surpass the threshold, then the clearance drops disproportionately in a very relatively small pattern. So what does that mean? As you can see here, the higher the dose after the threshold, then clearance disproportionately goes down. So clearance goes down when there is a higher dose surpass the range. And also the rate of elimination is no longer increased proportionally. Instead, it goes non-linear change. And so is the concentrations goes up in a rapid dramatic way. So let's do another pictures to contrast the first order to Michaelis-Menten, or the mixed order. So imagine for the world of first order medications, the eliminations of a drug is the clearance functions in the kidney could be pictured as a fishnet versus a fishing pole. So a fishnet that contains a fixed valence to remove a drug or a fish from the fish tank, right? So first order, that the clearance as the value of the fish net is constant to remove a certain level of drugs in a fixed time, and there is no saturation issue. And when it goes to the mixed order or Michaelis-Menten model, the fishnet now, as the clearance, it is replaced with a fishing pole, so which means it has a saturated up limit in terms of the metabolism. So the fishing pole tries hard to get rid of the medications as each fish in the fish tank. However, each fishing pole has its limit to contain a certain amount. When in a mixed order elimination, Each fission pole is like the enzymes with capacity limits in the liver. When the removed demand is less than the capacity amount, then that is the whole system works as responsive in first order. But when capacity now limits is approached, then the metabolic rate becomes more constant, as getting slower and slower when the system gets towards saturated. Theoretically, the bullet point here, theoretically, it least happens to any medication that is metabolized in the liver that when at high enough concentrations. But we seldom give least particular attention to all the metabolized medications, but only to those clinical significance in medications which is expected that the saturation occurs at the very easily observed as a standard dosing regimens. So these medications are all have these another in common, that is very narrow therapeutic window. So here are the equations I listed for you. No worry to remember all these, but if you have interest in, feel free to. So what should we learn from this? This is everything about the Michaelis Menten or the mixed order medications. At steady state, that when the metabolic saturations goes to the steady plateau constant, the metabolic rate will be equal to the daily dose in this MM model. So the rate of metabolism is approached to the daily dose to be removed, and that is the Vmax times the steady state concentration, that's eliminated by the both Km and the concentration. So on the right corner, I listed the plot of the daily dose to the clearance. Here you can observe the Km is just as the slope here that adjusts the changing in clearance when the daily dose changed, and the Vmax vice versa is just calculated as dose times up with the Km at the concentrations divided by the concentration its own. So how can we get the Km in the mathematically? It's just you just need the two regimen as the two daily doses and their own concentrations in the steady state. Then you can know the Km as the equation here, and that is pretty useful. I will explain in a second. So another big point to mention to you, why the Vmax and Km here is particularly important in the mixed order type. So the Vmax divided by the Km is called the intrinsic clearance. These two important parameters determine the intrinsic clearance of those hepatic metabolizing enzymes. Vmax here is so called as the daily amount in milligram as the unit. Vmax is the rate which liver can metabolize the drugs at its full capacity. Alright, so it's the capacity as the unit. However, the Km here is so called as the Michaelis constant. It's a constant that individualized in each patient. So Km is just like the concentration unit, as for example as liter per milligram. And these two parameters, once Vmax or Km are estimated, and then followings can go on and determined with both equations here. So these two common scenarios are clinically often needed, as we would like to know the new dose regimens to be needed to achieve a desired or assigned steady state concentration as your goal, or you just have the new regimen order and you would like to predict the new concentrations in a steady state. So these can be both translated with these equations. On the other hand, the Km here as the Michaelis constant has another important clinical point, the Km can be inferred as the drug concentration at which rate the timing of the rate of drug metabolism is equivalent to the half of the Vmax. So let's look at this chart, this plot. The clearance to the daily dose as the slope as the Km, and here you can see when the dose towards to half of the Vmax, that is the half of the most capacity that the enzymes can remove the drug in a day, right? So when the dose is approached half of the Vmax, then the Km at the time is just exactly the amount at steady state concentration at that point. So what can we further infer from this is when you observe the steady state concentration at a certain point, first when it equals to Km itself, then that means the daily dose we are giving the patient now is half of the max capacity that the patient's liver can remove the medication. And when the steady state of the concentration under the given regimen, and when that is less than Km, then that means there is a far way to go when the metabolism towards its limit zone is still less than half of the Vmax. However, if the steady state concentration is more than Km, that means now it is getting toward to the higher range, higher threshold, and the daily dose is just more than half of the Vmax that the patient's liver may be just able to handle. So the enzymes are closer to the saturation status, and once surpassed that point, a mixed order pattern could be emerging with higher concentrations presents with the toxicity. So precautions with this steady state concentration and Km. All right. Then another important pharmacokinetic parameter that we always looking for is half-life, or the time to steady state. If you can remember in first order, we would like to apply several equations such as the half-life goes to 0.693 divided by the eliminate constant K, or the time to steady state is 4.3 of the half-life as a 95% steady state reached. However, these both equations is not able to apply in the Michaelis model. This only followed in the first order word. Those are the concepts. So remember, the elimination rate is no longer proportional here in the nonlinear models, right? And the clearance is variable too. But don't be too disappointed from that, because phenytoin still has a half-life, but just that changes a lot, especially when a serum concentration is changing. So we cannot merely rely on the half-life calculations to get a 95% of steady state reach. So here is an alternative equation I provide to you, but we do not normally apply this equation in clinical situations. but just for your reference to know, these still can be inferred mathematically. But instead of calculating, not only to try to calculate it out, instead we would like to picture it into a visual algorithm or a nomograph. So here is a nomograph that you could have a sense for that. As the plot goes to the days of applying phenytoin by the blood concentrations of phenytoin as the concentration here. And these different curve stands for different daily dose of the phenytoin from the 300 milligram to up to 425. And as we can notice here, the lower daily dose of phenytoin, such as 300 milligrams, the concentrations of phenytoin getting to its plateau's stage at near to the 4 to 5 days. But when the daily dose of phenytoin goes up, it gets longer and slower for the concentrations to get to its plateau state. So that means the steady state times is longer when the daily dose is larger, if that makes sense to you. And sometimes it may take weeks when of a higher phenytoin doses to reach its steady state. So it needs be really cautious with. So remember, the closer the dose is to the Vmax, the longer it takes to get to the steady state. And during these all various parameters, there are only two reliable constants here in the nonlinear model. Is we need to get the Vmax and Km out. Alright. So before we dig into more applications, let me quickly provide you with several characteristics of phenytoin in a clinical way. As pharmacokinetics, we will always look into the four abbreviations, the A, D, and E. The A is for absorptions, and the unique of the phenytoin is not only as a nonlinear aspects, but it has the lipophilic, is highly protein binding, and when we saying that high protein binding normally means above 80%, that is of the medications in the systems is attached to protein. But here for the phenytoin, is usually the normal binding rate is up to 90% bound. So only 10% of phenytoin is unbound. And then is hepatic induction. So it induces is not only influenced by the metabolism systems in the liver, but also it induces other medications effect by influencing the enzymes in the hepatic systems. And also as for the adverse effects, as we know that this is a very narrow therapeutic window medications, it is concentration dependent. So we need to know both important range, that is a therapeutic range, and also the toxicity levels. So for the therapeutic range to control the active seizures by using phenytoin, we are expecting to target the total range as a total concentration in between 10 to 20 microgram per milliliter. And if that is the therapeutic goal, by measuring the free-formed concentration of phenytoin, or called the unbound formed phenytoin level, then that is just 1/10 of that. So it's from 1 to 2 milligram per liter. But if that is the toxicity level, it starts it can happen immediately when the total concentration goes above 20. And you've observed by following adverse events as the concentrations goes up. from just have the eyeballs as a nystagmus signs, or patients becomes with an involuntarily movement of the limbs as ataxia, or starting had a slurred speech, or getting confusion, getting lethargy, and even presents with the coma status or with another new wave of seizure attack. So yeah, you hear it right. These anti-seizure medications is not only able to control the seizure, but also able to induce another new wave of seizures by controlling its mechanisms in the brain systems. So anticonvulsants, sometimes it has the seizure causing effect and its toxic level. Some other facts about the phenytoins in the PK part. First is most of the time phenytoin is not comes as its own. It often comes with a sodium based and with a ratio of about 92% of phenytoin. So we will convert a salt factor to consider if you need to convert the phenytoin sodium as a salt product to its pure phenytoin molecule. So remember to times the 0.92 as a salt factor. And the overall foam phenytoin normally is 100% really well absorbed. However, if that is in the injectable form, if that is in IV form, first remember the administration route is intravenous only. It's not able to access through the intramuscular, because it would cause severe risk of the local tissue destructions or necrosis. And also the phenytoin itself is not really has a good soluble, so it needs as the diluent as the propylene glycol. However, this PEG is really has its downside as a cardiotoxic. So if the administered phenytoins IV form with a higher speed, and that sometimes the patients would cause hypertension from that. So we would have to control the IV rate at a certain range as listed here. And then the IV form phenytoins is only accept to choose the normal saline as a solution. We do not administer or mix it in the dextrose because it will cause a precipitase. And another common alternative to avoid these downside for the reconstitutions of phenytoin is the prodrug form of the phenytoin, that is the false phenytoin. So you can choose that as alternative if that is available to you in your country or in your institution. As for the volume of distributions, it goes in larger per kilogram in the neonates than in adults, and also because it's really hypophilic, so we always So the value of distributions in the phenytoin is distributes in larger volumes in neonates compared to adults, and because it's high hydrophilic aspects, so we will quantify as the using by actual body weight for the value and estimation. However, if we are dosing for the obese or to estimate its value of distribution, remember to using an adjusted body weight here as the ideal body weight plus the 1.33 of the difference between the actual body weight to the ideal body weight. And because phenytoin is another aspect is up to 90% high protein binding. And as for the metabolisms, we will have to remember that only unbound phenytoin here can penetrate across the brain barrier to stop the seizing. So pursuing the free fractions or the unbounding fraction here is important because the only change in the free fraction can be clinically significant. So it highly depends on the unbound level. That is, the FP is normally 0.1, and we will also need to pursue the clearance here. And the clearance is that goes up with the Vmax divided by the Km plus the concentration. Here are just some average data that we use if the individualized blood concentration is not available in the first second. So the Km for the adults, we were using the average of 4, and for the Vmax here we use the 7 milligram per kilogram per day in average. As for clearance, it is not constant, so you have to refer to nonlinear kinetics. As for to determine the loading dose and the maintenance, that is importantly to know what kind of different body weight that we need to choose. So the loading concept here is when your patient is seizing, we would like to stop the seizures as soon as possible. So we need to load the dose to increase or to ensure the concentrations goes to the effective level in a short time as possible. So loading dose normally is higher than the maintenance dose. So is in antibiotic concepts, and so is in anti-seizure medications. So the common dose of the phenytoin loading starts from between 15 to 20 milligram per kilogram, and the maintenance is normally half to a third of it, so from 5 to 7 milligram per kilogram per day. If we are dosing phenytoin to non-obese patients, then we use the actual body weight. But if the patient is at obese stage, then for the loading dose, you need to using the adjusted body weight as equations correctly to avoid to overdose by using the actual body weight for the obesity population. And for the maintenance dose of the obesity patients, we use the ideal body weight instead. And in terms of the important timing of differentiating when should we give patient a blood drug to check the phenytoin level, there are several indications of sampling. First, when there are any change in the concurrent disease status or the drug therapy, if the patient has been changed from the clinical condition from stable to start seizing again, or if you just change the therapeutic change the latest therapeutic regimen and you need to ensure if that is effective, then you have to follow by order a blood drug or phenytoin. And when there is lack of adequate response to previously those that's in effective regimen. Third, if the patient starts to present any of the suspected side effects of the phenytoin, then we need to get a toxicity level at the proper trough time to ensure if that is because of the phenytoin's use and try to deal with from that. In terms of the exact time of sampling, for the loading dose, you can quickly to check the first blood drug after 2 hours of the finish the loading. And if just for the regular maintenance dose, then we need to follow the trough level as the both therapeutic and safety target. Normally within 1 hour prior to the next dosing time is practically acceptable to refer the true trough level. And then as the third timing of sampling for the maintenance dose is important to determine when is the steady state. However, it could be really confusing because it normally ranges from less than 3 days longer to weeks here. So just provides you with some more tips. We normally divide patient groups into two categories, from stable to unstable status. So if you are dealing with a stable patient, that patient stops seizing already, getting normal, about to discharge, then normally the one steady state timing should be any time if the patient had used for a long time of the phenytoin, and also the compliance is good. So you could just pick random level to assume that is the steady state timing, and repeat at steady state after each dosage adjustment. But if that is for unstable patient, then especially just starting its first use of phenytoin after the loading dose, then we would pursue normally starting the first check of the maintenance level, trough level on the 3rd to 4th days, and then weekly after. And be aware of that if the patient is not just using a normal daily of 300 or 350 milligrams, but instead of a larger dose, then you may want to wait for 2 or 3 days later, then just 4 days, to ensure there is a really plateau concentrations of the true steady state coming. But if you are still not sure about that, how should we deal with that? We just weekly check afterwards to ensure there is no more fluctuations. All right. And as for the timing of getting a free form of phenytoin level, but it depends on the capacity of your laboratory. If your laboratory people are able to get whatever, whether the total form concentration or the free form phenytoin concentration is both good to your patients, but normally we would just we would just get the total form phenytoin and then calculate the free form. However, there are still several specific conditions that order a free form measure of free form phenytoin is vital, and those timings often refers to a total form phenytoin is not reliable. So, for example, when the total phenytoin dose, if we are dosing as a larger of the maintenance range, but the total concentrations comes back and is below the expected 10 to 20 therapeutic range, is under therapeutic, then that is confusing, and you have to exactly knowing if that is the true effect, if the total concentration is reliable or is not. And then second, if a patient is seizure-free, seizures getting controlled at a total level of below 10 milligram per liter, and you need to determine if the phenytoin dose increase is necessary, if the increase is necessary, or you need to taper down, then probably you will have to get a free phenytoin level just to ensure you are not causing the seizure once you decrease the dose, if that makes sense to you. And third, if the patient is exhibiting any potential toxicity signs at a dose of below normal maintenance dose and has a total concentrations below 20, but if there is any signs that is suspected to be adverse effect, then just get the free phenytoin concentrations to ensure it's not above the targeted 1 to 2 milligram per liter in terms of the free phenytoin. And last but not least, if the patient is in a unique subpopulation following by any pregnancy women, or if patient is on multiple anti-epilepsy medications, or is they are pediatrics, the peds, that is especially not no more than like 6 months age. So because the volume of distribution concept is quite different in those subpopulations, so a free form is more reliable than just measuring the total form. All right. So in terms of if you want to determine patient-specific Vmax or Km, here are 2 scenarios I will provide you here, as whenever you have 2 different maintenance dosing regimens specifically, and you can try to get the steady state from these 2 and to get the Vmax and Km. And remember about the unit, you have to do using it right in terms of calculated and translate. Another scenario is if you have the level comes back, and you would like to making any decisions in the dosing modification. So dosing adjustment can base on the previous levels by the level and the new determined concentrations, right? So here are the scenario if you have only 2 if you have both 2 different steady state levels available, or only one or none of the blood draw has been checked yet, then just can get the patient's own Vmax or Km, or can only use the population average Vmax or Km instead. And another reminder here is when you are dosing, calculating the dose, here is it means the daily dose here. But if the this equation only applies for the phenytoin, so if the dosage is in a sodium salt form, then you need to multiply the 0.92 as the salt factor. And another important scenario may be the most important things of the whole section here today is to assess a phenytoin level when the protein binding is not normal. So what is the normal protein binding? If you still remember, the normal range of the protein binding of the phenytoin is 90%. But there are not only 2, but the major 2 risk factors for changing this disposition of protein binding are first, the lower serum albumin below the normal range or second, if a patient has renal failure condition. And why is that? Because when either situation happens, if the patient has a lower level of the serum albumin, or the patient has the creatinine clearance less than 25 milliliter per minute, then that decrease the available protein binding site, or medications would be displaced forcibly from those binding sites. So that means the free fraction, the AFP, will increase instead. But at a very important, when this new changing becomes stable, reach to a steady state, then the clearance will go up because the free fraction goes up. And what happens when the clearance goes up? Eventually, the total form of the phenytoin concentrations will go down. So what does that mean? The decrease of the total concentration does not apply as the patient is under therapeutic. Instead, the free concentration remains constant or remained unchanged during these situations. So the patient might still be therapeutic according to the free phenytoin concentration, but presents as the subtherapeutic in the measure total concentration because of these changed. So if you know this fact, you can protect your patient from getting overdose by just checking the total concentration and thought the patient is under therapeutic. But so these are really important concepts to keep in mind when you are dealing patients with the lower serum albumin. For example, if a patient is in the sepsis state, if is in severe septic shock state, is in any increased surge state, and if the patient is like a burn patient, or the patient is in the ESRD stage, then these will all impact the patient's phenytoin level. The total concentration levels will not be as reliable as the regular situation. So we have another calibration equation to address this condition, that is to adjusting a total phenytoin major concentration to account for the decreased situation in albumin. So in this calibration, you can get the ordered the total form concentrations as the measure, and then divided by the renal function constant x. When the renal function is normal, then the constant is 0.2. If the patient has the renal failure status, then times 0.1. And so using these constants times albumin level and plus 0.1, so this is the calibration equation to get the normal situations of the protein binding to get the calibrated concentration of the total form. So oftentimes after this situation, after this calibration, the adjusted total concentration level would go up, would increase compared to the measured total concentration. So here is a scenario I provide you. I encourage you to think together that patient RF has an underlying CKD stage 5 in its severe renal failure, but is pre-dialysis. So he is still not hesitant to get dialysis yet. And today, RF admits to the emergency department due to an acute seizure attack. And the major level laboratory data as following: that the serum creatinine is 4.0, and the serum albumin is 2.4. And according to his chart, RF is taking 400 milligram per day of dilantin, which is phenytoin or foam form, and his steady state concentration right now and in the ER checked was measured to be of 10.0 milligram per liter. And according to this total form level, his physician has just written a new prescription to modify, pursuing for a higher daily dose of 300 milligram twice daily. So if you are a pharmacist or you are a clinical provider, what dosing strategy would you do as the clinical people on site? Would you agree to increase the regimen to upper dose, or no, let's just keep it as the 400 milligram, or C, to not increase or keep it, I would like to decrease the dose because I do not want the patient to be over or enter to the therapeutic side effect level. Or D, I would like to try some other agent else, let's discontinue the phenytoin. So here is the question I challenge you to think about. There may not be a true answer, but there definitely will be the answer to avoid from, and that is A. And for your reference, here I list you several anti-epileptics that we often choose, and that is available in our hospital's formulary to our ICU patients. And so starting with the first generations of anti-epileptics, that including with both oral form or IV form available, that is the most common as a phenytoins and valproic acid. And if that is in terms of carbamazepine, is an old drug but is only has the oral form available. So in an acute situations of the acute seizures, that is less chosen, because you like to tend to select the intravenous form. All right. So and then the second generation of the AED here, level are two L letter. The levetiracetam that has both oral form and IV, so is the lacosamide. And as for the oral form, there are you can choose whether topiramate, lamotrigine, or azcarbazepine and pregabalin. Then the third or the newest generations, including as brivaracetams and also the perampanel, and the brivaracetam is the similar structures to the levetiracetam, and in other hospitals has the IV form, but in our hospital in Taiwan only has the oral form. As for the mechanism here, that the different groups goes follow in different types. So many of the AEDs can modulate the voltage-gated sodium channel, and these would be expected to decrease the depolarization-induced calcium influx and the vascular release of neurotransmitters. In addition, lacosamide, such as so-called Vmax in its product form, is thought to enhance in short here is the LCM, is thought to enhance slow inactivation of the voltage-gated sodium channels. This effect is different from that of other AEDs listed, which are thought to enhance fast inactivation. And levetiracetam or brivaracetams are the only available drugs that bind to the SV2A, which might have a role in neurotransmitter release. And last but not least, like pregabalin is able to controlling the calcium through the PQ channel, and topiramate and the perampanel is controlling the AMPA channel. And then the last group as benzodiazepines or barbiturates, topiramate, have been found to enhance inhibitory neurotransmission by allows terrically modulating the GABA receptors mediated chloride. So in another as the mechanisms categorized, instead of just the generation of the drugs comes out to the market, I would like to categorize these by following colors for your reference. Like the valproic acid, phenytoins, and the lamotrigines or the azcarbazepine by impairing the sodium channel related, that goes to these categories. And the levetiracetam, brivaracetams controlling the SV2A, that falls to the another type. As for the lacosamide itself, enhanced by slow inactivation of the voltage-gated sodium channels, as another type. As for the drug interaction that we just mentioned, you could probably notice that many seizure control medication has its effect function as not only enzyme inducer its own, but also inhibitor. So here is a table I provide you, and also with several protein binding as the listed above certain thresholds. So you may notice a lot of the anti-seizure medications are high protein binds, including from the phenytoin we mentioned today, also the valproic acid, and the carbamazepines, and then the perampanel. So understanding the art of phenytoins, I often explain that to my colleagues is a dying art. Although phenytoin is not that commonly used nowadays, as long as new anti-seizure medications coming out. But if a patient has ended up on receiving phenytoin, then that instantly can explain the patient is in a relatively critical ill stage in terms of the severe or difficulty control of seizures, or sometimes as the status epilepticus or refractory RSE, refractory status epilepticus. So by this topic, I'm hoping that everyone can understand there is still a role to improve our clinical pharmacokinetic concepts in controlling, in helping our the patient that has been seizure can get a prescription right and safe at the same time. So some take home points today. The first, we emphasize a lot on the disproportional concept in nonlinear model that is heavily relies on two new constants in Michaelis Menten words, that is the Vmax and the Km. Second, phenytoin nowadays is not just the only one that goes with the nonlinear model, but just an exceptional, very classic one. So we choose phenytoins as a demonstrations to you. Third, there are several key points to the clinical pharmacokinetic aspect in phenytoins, include from the ADME, from absorption, distributions, elimination, then the the metabolisms, include the fluid understanding in therapeutic features, and also in its nonlinear equations, and when should we get the order right, when is the right indicator to order a blood check sampling, to order which point of the concentration curve is the trough or the peak, to check for whether loading dose or the maintenance dose, and with the critical parameters collected as well. So hopefully after today's sessions, get good luck with the phenytoin cases. Thank you for your attention. Here is the reference. If you have more further interest, feel free to look into.